Bronchiectasis. Understanding the disease, diagnosis and management. Good morning everybody. So why is bronchiectasis important? It is a chronic progressive lung disease, increasingly prevalence due to better diagnostic tools and aging population. So significant morbidity, frequent exacerbation, that is attack, and impact on the quality of life. So the objective of my talk is explain the pathophysiology and causes, discuss clinical features and diagnostic approaches, highlights the management strategy including emerging therapies. So let's start with definition and epidemiology. Bronchiectasis is a chronic lung disease characterized by irreversible bronchial dilatation due to inflammation and infection. In a global burden, higher prevalence in developing countries, often underdiagnosed or misdiagnosed as a chronic bronchitis or asthma. So, in a pathophysiology, core mechanism is persistent infection can lead to chronic inflammation in which airway wall damage occurs, which causes permanent dilatation, and in vicious cycle the inflammation causes mucociliary dysfunction, that is our defense mechanism, which causes bacterial colonization, further increases inflammation. Key structural changes are bronchial wall thickening, mucus accumulation, recurrent infection. So, in causes and risk factor, first is a congenital cystic fibrosis, most common inherited cause primary ciliary dyskinesia, in which impaired mucociliary clearance in acquired post TB because of tuberculosis, pneumonia and or a viral infection. In obstruction, there could be a tumor, foreign bodies, and in immunodeficiency syndrome, which could be HIV, hypoalbinoglobulinemia. Idiopathic causes a significant proportion. Fourth is a clinical presentation. So what are the key symptoms? First is a chronic cough with copious mucopurulent sputum, hemoptysis, which could be blood streak or massive. recurrent chest infection. There could be wheezing, shortness of breath, that is the breathlessness. In a systemic symptom, weight loss, fatigue, clubbing in severe cases, and on physical examination, findings are coarse, crackle, rhonchi, digital clubbing in advanced cases. In a diagnostic assessment, first is a high resolution CT, that is HRCT, which is a gold standard for detecting bronchiectasis, and its findings shows dilated bronchi, that is a tram track sign, signet ring sign, mucus plugging. In pulmonary function test, there could be a obstructive or mixed pattern. In a microbiological studies, sputum culture shows common pathogen including Pseudomonas aeruginosa, Haemophilus influenza, mycobacterial culture for non-tuberculous mycobacteria, that is NTM. Blood test. Most important is the immunoglobulin levels to check for immunodeficiencies. In bronchoscopy, in selective cases, to rule out malignancy or foreign body obstruction. And in management and treatment, first is a most important is a airway clearance therapy, chest physiotherapy like postural drainage, active cycle of breathing. In oscillatory devices, flutter, echeplia, hypotonic saline or mannitol inhalation to aid mucus clearance. And in antibiotic therapy, in acute exacerbation, in acute ataxia, empirical antibiotic covering Pseudomonas and Haemophilus. In chronic suppurative therapy, inhale or long-term macrolides, most common is azithromycin. In anti-inflammatory therapy, macrolide, for example, azithromycin, have immunomodulatory effects. In a bronchodilators, used in a patient with airflow obstruction, and in a surgery, it has got limited role reserved for localized disease or severe hemoptysis. There are emerging therapies also like inhale antibiotics, for example, ciprofloxacin, tobramycin, novel mucolytics, Dormes alpha, mannitol, and in biological therapy in which targeting IL-5 and IL-17 pathway, anti-biofilm strategy. new therapy against Pseudomonas colonization, gene therapy for cystic fibrosis related bronchiectasis, future potential. Now in preventive strategies, vaccination, yearly vaccination of influenza, pneumococcal, pertussis, smoking cessation means stopping, essential for disease control, regular follow-up for symptom monitoring and infection control. There are certain case studies. A 35-year-old patient come with the blood stick sputum, HRCT shows bronchiectasis and was successfully managed. So, in conclusion, key takeaway in bronchiectasis is a chronic but manageable disease. Early diagnosis and a multidisciplinary approach improves outcome. New therapies are promising but require future research. And in the final message, importance of awareness, preventive care and patient education. Thank you.